Okay, so this is part, what, 4? Part 4 of the January 5th workshop on the lower leg. Now, a key trick with all of this is just going to make sure you work on every part of the leg in every position. And maybe trying to, so if I just think in quadrants, the thigh versus the lower leg. If I turn the person, if I work on the thigh in prone, supine, and sideline, I'm gonna naturally just hit all the structures by just changing the client's orientation and some of my angles. The lower leg, if I just work on the lower leg in every single one of those positions, I'm gonna naturally get good access to those structures. So a big part of this is get more comfortable with sideline. But I will cover adaptations when you can't work in sideline or you're limited in time and you have to pick and choose. So something that gets lost, I lost a glute, that's okay. The shin muscle, so the anterior leg, anterior lower leg. All these muscles just on the lateral side of the tibia. Nothing on the medial side, nothing over there to worry about. All the muscles are on the lateral side of the tibia and come over and attach onto the fibula as well. But there's 2 compartments there. It gets really easy to just say shin muscles, right? To think of this all as one unit. Whereas the most anterior chunk of these, the stuff that sits right next to the tibia, just on the very lateral side of the tibia, that's all those muscles are about dorsiflexion or toe extension. So dorsiflexors and foot or toe extensors live in the same neighborhood. They're paired together. But if we keep going lateral to those over onto the fibula, we end up on the peroneal muscles or the fibularis muscles. Those are just synonyms. The old terminology for it is peroneal muscles, peroneus longus. Things are shifting now to fibularis, so like fibularis longus. So there's 3 of those, fibularis or peroneus longus, brevis, and tertius. Those are everters. Those just function at the ankle, they don't do anything to the toes. Okay, so it's just remembering that the shin muscles, there's 2 groups. There's 2 groups there. It's much easier to get on those shin muscles in sideline. When they're laying supine, especially if their leg tends to externally rotate on you, that's hard for you as the therapist to get to. So either you gotta turn their leg in so you can get to that stuff better, or you just put them on their side. And that top leg, you can get to it much more effectively. So important muscles to just think about right here. And addressing both those compartments and thinking about those movements, just mindfully. And remembering those fibularis peroneus muscles. On the posterior side, the big ones, gastrocnemius, and then directly underneath of that, soleus. Those 2, along with plantaris, become the Achilles. Okay? I think plantaris becomes part of the Achilles. Some people don't have a plantaris. I'm trying to remember if plantaris is all by itself or it's only soleus and gastroc. I tend to second guess myself and find out that I'm usually right, but try to curb that. But speaking for gastroc and soleus, those are the ones people tend to concentrate on the most for the posterior calf. Only those 2 come down and become the Achilles. So as far as ankle function is concerned, they only do plantar flexion. But underneath all of those is another group of muscles. So for tibialis anterior, there's tibialis posterior. For extensor hallucis longus, extensor hallucis, there's a flexor hallucis. For extensor digitorum longus, there's a flexor digitorum longus. But it's all underneath gastroc and soleus. And the only way I can access those is on the medial portion of the calf. Since they're underneath of it, like this, the only way I'm really going to get to those good is by coming in on the medial portion of the calf and trying to work kind of underneath gastroc. The way I tend to think about it is I'm trying to pull gastroc and soleus away from the tibia so that I can make more room for these muscles underneath. All of those muscles have to go down just posterior to the medial malleolus, the big bump of your ankle joint, and go down to the arch of your foot. And then you have all of that stuff. So there's a huge interconnection in relation to the muscles on the medial side of your foot, thinking the arch, into the posterior lower leg. So if I'm going to help somebody with their ankle movement, I have to think not just about gastroc and soleus, or just about kind of losing everything. It's a hamstring. So, but I can't just think anterior shins and then posterior calf muscles. I have to think about these other structures related to the ankle that have to do with eversion, inversion, plantar flexion, dorsiflexion, and then the toes as well. And the easiest method I have for that is just to work on the lower leg and sideline. Because you can do a really good job, especially for the calves, maybe in prone. I frankly can do a much better job for those inside line. But the top leg, inside line, I can get to all those shin-based muscles, the ones that do dorsiflexion extension, and then the everters, the fibularis group. The bottom leg and sideline lets me get to everything that's the antagonist to those, so the inverters and flexors of the toes. That's the quick 2 cents on that. And then once we get to the knee itself, I've lost notes here. The nice thing about the posterior leg is it's just the hamstrings. That's all you got. And all the hamstrings cross both the knee and the hip. At the knee, they split. So at the knee, they split. And on the medial side, you have semitendinosus and membranosus attaching down onto the tibia. On the lateral side, you have bicep femoris, which is coming down, attaching onto the fibula. But up at the hip, they unify, essentially come all together at one attachment site at the ischial tuberosity. That bony knob that you see at the bottom of the pelvis. So all the hamstrings have to come up down here, showing a bone model here. That right there on the ischium. Now, the problem with getting to the hamstrings, the lower, about halfway down, and then closest to the knee, easy to get to in prone. But getting to this higher part up near the pelvis can be more difficult. So again, sideline. When I turn a person on their side, I can much more easily get to that, especially that proximal section up near the hip. And when we're talking about the firing pattern stuff, it's the high hamstrings, the glutes, and your low back muscles, the erector spinae, that are all working together to take the hip into extension or hyperextension. But finding a way to just get onto those higher hamstrings is so important. The reason why people don't do it is because underwear gets in the way and the draping's awkward and people get scared because they're up near the groin and the pelvis. So even if you have to go over the sheet and getting to that higher aspect of the hamstrings becomes really, really important. Not just down here. If I have a key thing to remind everyone on related to the hamstrings, is if I were to divide them in half, the proximal portion nearest to the hip is supposed to be more about hip extension and hyperextension. And the distal half is supposed to be more about knee flexion. So I have to be aware that the hamstrings have to do 2 jobs. They're a part of hip extension and knee flexion. And they have to the fibers have to change which one is their dominant duty based on which joint they're closest to. And the neck structures of the hip if we're coming over, thinking about stuff that interrelates. The adductors. Let me flip that around, just because it's agonist, antagonist. So the antagonist of the hamstrings, the quadriceps, right? Now, one anterior thigh muscle, really I can say two anterior thigh muscles that we did talk a little bit about, sartorius and tensor fasciae lata. Those have they're superficial, and if I am saying that IT band is the tendon of tensor fasciae lata, then both of these cover a big space. They cross two joints. So the IT band and tensor fasciae lata, tensor fasciae lata is predominantly a hip flexor or internal hip rotator, but it does help control the tone of the IT band all the way on the lateral side of the leg. Doesn't function at the knee, but it does come down and cross the knee. And then sartorius does a strange S shape from across the whole front of the thigh. Being able to palpate sartorius all by itself is tough. So we're going to be thinking much more about just the quadricep muscles themselves, the four quads. Rectus femoris, the most superficial one, is the only one that crosses both joints here. So sartorius does, but as far as the quads are concerned, only rectus femoris works at the hip and at the knee. After that, the next three, vastus lateralis, intermedialis, and medialis, only work at the knee. And there, the goal has always been, in PT, strength and conditioning, and when we look at the firing patterns, it's trying to make medialis stronger and turn off lateralis. Maybe you need to think about rectus femoris and intermedialis being stuck down to each other. That's kind of a common thing for them to get a little bound up. And rectus femoris does do a lot of work, so you don't want to over concentrate on just lateralis. Keep in mind that when you're pushing straight down on the anterior portion of the thigh, you're pushing through rectus femoris and then getting to intermedialis or intermedius. But usually the goal will always be get medialis, vastus medialis stronger, inhibit the other ones. With the adductors, you have the 5 adductors over here. The interesting thing with them, the anterior 4 are synergists with hip flexion. Only magnus, the big giant one, which is attached more posterior compared to those, helps with hip extension. We had talked about abductors and adductors being balance muscles, but a thing that can happen is that they'll call it synergistic dominance, where these balance muscles start firing too much when a person's trying to flex and extend their limb. So a person, what's supposed to be happening is they fire their hip flexors to bring their leg forward. But if everything in these balance muscles has been adapting for too long and they start contracting too much, that'll limit the mobility too. So if somebody has gait and or balance issues, looking at the adductors and the abductors can be so important. Coming over to those abductors, tensor fasciae lata has multiple jobs. So abduction is one, internal hip rotation is one, and it does fire with hip flexion. Then you got glute medius and minimus. Those are abductors. The one that you'll palpate most easily is glute medius, because that's just the most superficial one. Then you end up over on maximus, which actually, based on how far you're going into a movement, certain fibers fire more than others. When we're looking at the firing patterns related to glute maximus, it's going to be about hip extension and then hyperextension. So, but it does do a little bit with abduction and some rotation stuff. It's a very big, important muscle with a lot of duties. The biggest problem with low back and or hip dysfunction is glute maximus tends to be inhibited and too weak. So the fancy new term on the block, it's not new anymore really, dormant butt syndrome. The glute maximus isn't working enough, so high hamstrings and your low back muscles start working too much. So typically what we'll be doing with firing pattern stuff is inhibiting low back muscles and or the high hamstrings and trying to get glute maximus to be stronger. Down at the knee for knee flexion, I didn't quite cover that one. What's supposed to happen down here is that gastrocnemius, since it is the muscle that actually goes directly behind the knee, the hamstrings split and go on the lateral and medial sides of the knee, versus gastroc attaches right up on the very posterior part of the femur. So it is important with knee flexion, but it shouldn't be the first one. For knee flexion, it should be hamstrings first, then gastroc. But that ends up being the ones that we're going to cover. It's knee flexion, think about the hamstrings and gastroc, and then knee extension for how the quadriceps are working, really wanting vastus medialis to be stronger. And then at the hip, we're thinking hip extension or hyperextension, where glute maximus should be the strongest. When we get to hip abduction, it should be glute medius is the strongest. When thinking firing patterns, the shortcut is if it's about the hip, it should be the glutes. And then at the knees, you're thinking just about the two movements of either flexion or extension. At the knee, for knee flexion, it should be hamstrings, then gastroc. That's an easy one because it's only two muscles. Over here for the quads, my shortcut is to just think that vastus medialis needs to be the strong one. You can inhibit everything else while not inhibiting that one. And as long as they're doing the movement extending their knee, we're hopefully getting that to kick on. So that's a quick, just anatomy refresher as we move in. So the next part will be me actually getting Renee on the table and just showing the optimal positioning for all of it, if we get the most can. All back together. Okay, I'm going to turn off the video, and we'll be on to the next part.